morning everyone, I am Dr. Sivaraman, final year senior resident, and I will be presenting my paper on outcomes of cervical kyphosis correction, a retrospective single center assessment with long-term outcome. This is the outline of my presentation. Cervical kyphosis is a rare debilitating condition, causes functional disability to the patient due to neck pain and myelopathy. Surgical correction of cervical kyphosis is challenging, and it is crucial to have realistic goals, and meticulous preoperative planning is necessary to help us achieve the desired outcome. Various approaches have been described. Posterior only approach is used for flexible or reducible kyphosis. A greater degree of deformity correction can be achieved using combined approach, but it's associated with higher complication rate. Recently, a significant degree of correction is achieved using anterior only approach with a minimal complication rate. Very few articles are available on outcomes of cervical kyphosis correction, which are small retrospective case series limited to etiology or surgical technique. The objective of our study is to analyze the safety and efficacy of various surgical approaches and the outcome both clinical and radiographic following this cervical kyphosis correction. Our study is a retrospective observational study from 2008 to 2023. All patients with cervical kyphosis who underwent deformity correction in our institute were retrospectively reviewed with a minimum of 1 year follow-up. Our study is approved by institutional review board. This slide shows the both inclusion and exclusion criteria to our study. Patient baseline demographics, surgical characteristics, and baseline and follow-up clinical and radiographic outcome measures were collected. This slide shows the clinical and radiographic parameters used to assess the outcome in these patients. This slide enumerates the neuric grading of 0 to 5, with 5 being more severe, wheelchair-bound or bedridden patients. And the modified Japanese orthopedic score of less than 15 is considered severe myelopathy. This lateral cervical radiograph demonstrates the method of measurement of radiographic parameters used in this study. All statistical analysis were performed using IBM SPSS Statistics version 26. A total of 52 patients with a mean age of 24.5 years with male predominance. The most common etiology in our series were traumatic, which accounts for 20 patients, and the apex kyphotic vertebra were C3 in 23 patients with a mean kyphotic segment of 3.56. Almost 23 patients in our study underwent posterior only approach, and followed by combined approach in 22 patients, remaining 8 patients in anterior only approach. This table enumerates the various frequencies of these combined approaches and the operative time and estimated blood loss. So almost 36 patients had a severe perioperative complication with a mortality of 3.85% due to ventilator associated pneumonia and sepsis in one, and cardiopulmonary arrest in the other patient. When comparing between the different surgical approaches, posterior only approach is compared with combined approach, which showed a significant difference, statistically significant difference between operative time and blood loss, and they had almost comparable complications between 8 and 10 patients in the combined group, but more mortality occurred in the combined approach group. So all patients had features of myelopathy, with moderate to severe myelopathy is seen in 78% of patients. And on comparing the preoperative and postoperative modified MJO score and neuric grading, it showed a statistically significant improvement in this, and the graph shows the box and whisker plot of both neurics in the left and MJO in the right, which shows statistical significance. And all patients achieved a significant deformity correction with a reduction of kyphosis from 44.2 degree to 8.87 in the study. And the mean follow-up was 72.96 months with a range of 12 to 240 months. And 2 patients were bedridden. All patients had significant symptom improvement. So this is an illustrative study of a 6-year-old male with quadriparesis. Patient had typical facies with flat face, crowding teeth and short fingertips, and he was diagnosed as chondrodysplasia punctata by the genetics department. On examination, he had myelopathy with a power of 3/5 in bilateral upper limb and 1/5 in lower limb. Imaging shows significant partial collapse of vertebra with kyphosis in C3 to C7 with cord compression. Patient was kept on preoperative traction, and weight was gradually increased from 2 to 7 kg. And the patient underwent stage 360-degree approach, initially in the anterior C5 to C7 corpectomy and cage placement, followed by posterior C2 lateral mass and D2 to D3 pedicle, and patient was kept on halo brace for postoperative arthrosis. Patient developed halo site infection for which wound debridement was done in the postoperative period. Follow-up at 19 months, patient is asymptomatic, neurological status same as pre-op. And this is a 23-year-old male with weakness in both upper limb and wasting for 3 years and difficulty in walking. Patient had on examination had morphinoid features and diagnosed as morphin based on Ginn criteria. Examination, he had power of 3/5 in bilateral upper limb and 4/5 in lower limb. This clinical photograph shows features of morphins with increased arm span, wrist sign positive and thumb sign positive with increased joint laxity in high arch palate. Dynamic cervical radiograph shows partially reducible cervical kyphosis. This imaging shows cervical kyphosis is posterior angulation of the cervical spine with flattening of cervical cord with cord signal changes. He underwent occipitocervical up to C5 fusion. At postoperative 5, he developed tingling and numbness with power deterioration, and on evaluation found to have junctional kyphosis at C5, C6 level. And he underwent extension of fusion from occipito C2 to D2 level. Postoperatively, symptoms subsided and his power improved to 4/5 in the upper limb. And at 64 months follow-up, he is doing well asymptomatic, and imaging showed evidence of kyphosis. So we evaluated the long-term outcomes of cervical kyphosis following surgical management in our cohort, and surgical correction can lead to improvement in both clinical and radiographic outcomes, and all patients achieved some degree of clinical improvement, and the degree of correction achieved in our study is comparable to the previous studies. And MGO, there was an increase of 1.6 points in this score, which is comparable to other studies. However, Mumami et al. Were able to show an increase of 5 points, which is probably due to the increased severity of his preoperative score in his study. And there was a difference of 0.63 in preoperative and postoperative neuric grading. And the complication rate and mortality rate is comparable to the other studies in our other studies, and 36% had a serious perioperative complication. So surgical kyphosis correction is a viable option. However, the patient and surgeon must be aware of both the immediate and post-operative long-term complication associated with the correction, and surgery should be decided based on that. The limitation in our study is a single-center retrospective study which lacked matching between various surgical groups because anterior-only approach had only around 8 patients. All patients have been treated by the same team and followed over years, which brings uniformity to our study. However, a multi-center prospective randomized control study is necessary to determine the ideal mode of treatment for this complex cervical kyphosis. So conclusion, surgical management, we should aim to achieve neural decompression, deformity correction and spinal reconstruction. Approach should be individualized based on clinical radiological evaluation. Surgical correction provided significant improvement in both clinical and radiographic in our studies. So long-term follow-up is necessary as long-term complications like junctional kyphosis or implant failure remains prevalent in these conditions. Thank you.
Thank you, Dr. Sivaraman. Nice presentation. A couple of questions from my side. One is, was all the patients operated by same surgeon or this was by multiple surgeons?
Multiple surgeons, same teams.
Because every surgeon will have
Yes,
its
yes.
own preferences, so that's first. Second thing is, in the second case of Marfan's which you showed, why was occipitocervical fusion done? Was there a AD also in that?
There was no AAD, sir, but it was done like 14-15 years back. So
Sorry?
it was done around 2015. So that time, they surgeon preferred occipitocervical.
Surgeon's
fixing,
preference.
yes.
So although there was no AD,
No AAD,
because surgeon felt that
because it's
whatever reason.
yes.
Okay.
Thank you, sir.